All right. So I'm not going to waste too much time but I do know that sincerely, some of us may have forgotten the details of data gathering, which is why I just did this very quick slide. So for your history taking, like many of us, we all know this already from the beginning. You would always explore the presenting complaint. Okay. So if the patient has pain, does anybody know how do we explore the presenting complaint? What is that mnemonic that comes to mind?
Facts.
SOCRATES.
Yes, Socrates, right? Yes, the Socrates. Thank you. So that's usually the mnemonic that comes to mind. For those of you that have written PLABs, honestly, you might find this very boring. Okay, so, but if you're just, like me, 8 years postgraduate, you've forgotten all the Socrates, ODPARA, prima cosa, PAMA course. I'm just here to give you a quick refresher. Okay, so, all right. So the S, what does the S stand for?
Sites.
The site, right? So you know your onset, your C is character, and of course you don't ask your patient, can you characterize the pain? Instead, you ask the patient, how does the pain feel like? You could give them examples, is it sharp or dull? But you ask, how does the pain feel like? What's the next one? Let's make it an interactive session. Huh? What's the next letter in the Socrates?
R. Radiation.
Yes. And how would we ask that?
Is there pain in any other site than the original one?
Yeah, so does the pain move anywhere, right? So this pain you're feeling, let's say in your tummy or in your chest, doesn't move anywhere else, right? So do you feel the pain anywhere else? Your A is your alleviating. Does anything make the pain better? The T is timing. So you want to ask about this pain. Is the pain there every time or does it come and go? Okay, is it there always? Does it come and go? Your E is, does anything make it worse? Then your S is your severity. Okay, and trust me, you need this. Like, you need to practice this. But however, your history taking is beyond just Socrates. Okay, so I'll tell you the other details that you need to pay attention to. So on a scale of 1 to 10, with 10 being the worst and 1 being the least pain, can you rate it for me? So don't just tell your patient on a scale of 1 to 10. Because some patients are tricky. They will tell you 2, but because you didn't specify whether 1 was the least or 10 was the worst, 2 to them is actually 9. You get, so make sure you're very specific about telling them to rate it. Now, there is a power for the next question, which is anything else. This question gets you information. So don't forget that, okay? So besides this pain you're experiencing, do you have other symptoms? Please don't say anything else. If you just say anything else, it just sounds really vague. But when you hear a doctor saying, besides this pain you're experiencing, is there any other symptom? It's different from another doctor that says anything else. Like, you have to show that you care about the person in front of you. You're not using them to gather data and get marks, okay? You are showing that you're concerned and you care about them. All right. Then after that, you do your review of systems. So for example, if your patient has chest pain, you need to review the other systems there. So if somebody has chest pain, you should be thinking about asking things about cough, about difficulty breathing, about fever, okay? So you need to explore the other symptoms. Or if from the data gathering, let's say your patient has chest pain that radiates to the jaw, what comes to mind? You can type it in the chat box. So when you get chest pain that is radiating to the jaw and to the left arm, what diagnosis comes to mind? Okay, so yes, MI, thank you, very good. Yeah, so you're thinking of a myocardial infarction. So because of that, you already know signs and symptoms of MI, right? So you know your patient will have sweating, right? You know your patient will have palpitations. But again, you're going to use patient-friendly language.
Asking if I can hear you. But I asked if you'll be able to time.
Excuse me?
Okay. Thank you. So,
all right. So we use the patient-friendly language, okay? So for palpitation, you will not say, does your heart feel like it's racing fast? Okay, so you always use patient-friendly language when you're asking your questions, okay? So then once so in your MI or your chest pain, do your review of systems. Ask about the chest, then you can go to the belly, then you can go to your head, and then you can just go to the rest of the body. And in cardio, you know you have to ask about legs. Because whether it's chest pain, whether it's heart failure, whether it's PE, right? You can ask about leg swelling or leg pain. So you have to have all these ideas in your mind as you go through the stations or as you ask the questions. Yes, edema, right? So leg swelling. Now, another review of system that is important, some people call it flaws, but it's just a mnemonic to help you remember other questions to ask. So have you noticed any fever? Have you noticed any lumps and bumps in any parts of your body? Have you noticed any feeling like your heart is racing fast? So you're looking for signs of tiredness, anemia, which you get in your cancer patients. Have you noticed any weight loss or any sweating? Okay. So again, the approach is your Socrates. So if your patient comes with pain, Socrates, review of system, your flaws. Okay. So write that down and use this approach. Yeah, there is no formula. It's just that, and the truth is that if you use this in every station, whether it's a knee pain, whether it's a chest pain, whether it's abdominal pain, you will not miss your diagnosis. Okay, you will not miss your diagnosis. By asking flaws, you are ruling out your fever is giving you infection, your weight loss, appetite, tiredness is helping you think about cancer. Okay, so you have to ask these questions to get an idea of what's going on. Then your review of systems again helps you narrow where the issue is, okay, and so that you don't miss out on any important things. All right, then the S is sweating. Sorry. Yeah, I realized I didn't mention the S. So the S there is sweating. Then you try to rule out other life-threatening or similar condition, right? So you guys saw that when we're doing when we said the chest pain that radiates, right? We add MI, we add PE. So you definitely want to rule out your differentials. But again, don't be so focused on, I would say, because the truth is if a patient has chest pain that is radiating to the jaw and they're having sweating, right? And there is no leg pain, you already somehow ruled out pulmonary embolism, okay? You're kind of ruled out pulmonary embolism. So you don't need to start asking the patient questions of pulmonary embolism all over again. Because when you reviewed your system, when you asked difficulty breathing, it helped you. When you asked about the character of the pain, is the pain there every time? Does it come and go? Does this pain spread? It has actually helped you to kind of narrow in the differential, okay? So it has helped you narrow in what you're working with. So you have to rule out other life-threatening or similar conditions. So think of things that, could kill this patient with chest pain. So even if your patient has chest pain and you think it's GERD, okay, so let me use GERD as an example. Your patient comes in, the patient says, I have this heartburn underneath my chest. It's more after I eat. It gets worse when I lie down after meals. I also feel the sour taste in my mouth. So you're thinking GERD, right? However, as a doctor, it's not safe for you to let that patient walk away, at least without thinking about cardiovascular disease. Okay, without thinking about a myocardial infarction or pulmonary embolism. So think of anything that could kill this patient, essentially. So you want to ask questions like, if it's female, do you use contraceptives, right? You're ruling out risk factors, okay? For the MI, you can ask about your risk factors, the diet, the smoking, okay? Besides the other symptoms, do you feel like your heart is racing fast? Do you have excessive sweating? Do you have pain in your legs? Okay, so that's what I mean by try to rule out life-threatening or similar conditions. All right. Yes, then after that, so you're now done with your initial data, the first part of getting your history. Then you want to ask them the chest pain or whatever they came in with, are they still having it? And have they had it before? Okay, because it will help you. So have you had any previous episode? So the next part we'll talk about is what people call your P3 maftosa. Okay, so that's what people call maftosa. Some people call it P2, P3 maftosa. Okay, but it's really important. So your P, one of the P's is previous episodes. The other P is past medical or surgical history. The A, can we type it? What does the A mean? Anybody remembers? What does the A stand for in your maftosa?
Medications.
No, the A.
Allergy.
Allergies, thank you. And then the M?
Medical history.
So your A is allergies, your M is
Family history.
medication. Yeah.
Medication.
Yes.
Traveling.
Okay.
Occupation. Social
Alright.
history. Anything else?
That's it. Perfect. Right. So you have to have that. Like, again, these are things that you have to have written down and you have to practice with them every time. So any medications, and when you're asking medications, ask including over the counter or herbal supplements, because on that day you're not the only doctor there are other doctors, right? So you want to stand out. So you want to ask, don't just say, are you using any medications? Are you using any medications including herbal supplements or over the counter? But I mean, if only thing you remember is any other medication, it's still better than not asking at all. Okay, so that's fine. But again, because you have just practicing, try to practice with that. So your allergies, do you have any allergies to any medication? And if they have allergies, you want to ask the reaction. Okay, so my patient says I'm allergic to penicillin. So I ask you, what reaction do you get? Okay, and then you can be further extra. I like to be extra, okay, to say, okay, I will note down this allergy in your patient's notes. Trust me, the examiners are going to be smiling because they're like, oh, okay, that's a doctor we want for sure, you know. So you want to be extra, okay? So do you have any allergies? Yes. Okay, what reaction do you get? Oh, I will make sure to take note of this in your patient note, okay? Again, we are acting, so just go in that flow. Then any family history, if you can ask specific family, for example, if you suspect pulmonary embolism, it's okay to ask any family history of blood clots. Okay, so you can ask any family history of blood clots. Then you can ask any other thing in the family. Okay, some people say, is your family fitting well? Again, find what works for you. Okay, find your voice, find your tone, find the best for you, find what is natural for you. Okay, travel history is relevant in some cases, but if you want to practice with it, I think it's fair enough so that the one time is relevant, you will not miss it out. Okay. So for example, in pulmonary embolism, you know that it's important to ask about travel history, right? So patient might have taken a long flight from Australia to the UK. Okay. So you want to establish that. Then your O is your occupation. So what do you do for a living and how are things at work? Okay. Then you can even be more extra and say, how has this pain affected your work? Trust me, there is no harm in being extra. Like, is that extra that would save you that 1 mark? You know, sometimes we fail this exam by a mark, 2 marks, and it's so painful to have to do it all over again because of maybe 1 mark or 2 marks. So don't be afraid to be extra. Okay, don't be afraid to, like, you're there in the room to show them that, you know what, I'm a doctor and I'm a good doctor. Okay, so that's what you're there to do, to show them that. Okay, so ask them, how has this impacted? I mean, if you started today, obviously you can leave that, or maybe the pain has been for 5 days. You can ask, how has this affected your daily activity? How has this affected your work? Okay. Then social is actually important. So in the UK, okay, when you're dealing with your patient, you're not just dealing with the medicine. And I think that's what makes a difference as well in some stations, right? You're not just dealing with the medicine, you're just dealing with the patient's psychosocial things, okay? All the things that are going on, all the things that could impact the patient. So you want to explore living conditions. Who do you live with, right? And how are things at home? Do you get support from your family members? You know, is everything all right? You want to ask those questions, okay? Again, you might think it doesn't change anything, but trust me, that's what will give you your 4/4, okay? That's what will give you your 4/4, trust me. If you just ask your medical questions and you think that's pretty much about it, you probably get 2/4, okay? I'm not saying that, but I'm just saying that be extra, put yourself out there. Don't be afraid, you know, to try to woo the examiner, okay? Your goal is to woo them. Then, so explore their living condition, explore how things are at home. Then your part of your psychosocial includes asking about drinking, asking about smoking. So, right, do you take alcohol? Now, if they take alcohol, that's a whole different story by itself, right? But we do counseling station. Oh, but let's just discuss it. I mean, so if they take alcohol, let's say you suspect your patient is taking too much alcohol. What questions come to mind? What is that mnemonic called? If you suspect your patient is taking too much alcohol, cage, thank you. So you want to cage your patient, right? So what is the C? Okay, let me be checking the chart as well. Yes, cage. So what does the C stand for?
Cutting.
Cut down, right? So have you
Yeah.
felt the need to cut down on your drinking? What is A?
Guilty.
Do you feel angry when people talk about
Annoyed.
drinking, right? Do you feel angry? What is the G there?
Guilt.
Guilt, right? So have you felt guilty about drinking? Okay. And then E is your
Eye opener.
eye opener. Very good. How do we ask this?
Do you take it as
Do you need a drink first thing in the morning to stay alert, right? So do you need a drink first thing in the morning? Okay. So this is what you would do if you suspect that you're patient. Yeah. Do you wake up and drink, right? So do you wake up and drink? So these are the questions you would ask. So if your patient is drinking too much alcohol, right? If you suspect, then you can counsel, then you can cage them. And based on if you get positive, you know, you have to counsel them on that. Okay. So your DESA, sorry, I didn't arrange the stuff according to. But DESA means diet, exercise, smoking, and alcohol. Okay. Yeah. So smoking, you ask them, do you smoke? And if they smoke, so it's not enough to ask, do you smoke? Okay. So don't ask, do you smoke, and jump to the next question. That doesn't do anything for you. You have to assess how much they smoke and alpha. Right? So how can you tell, or just say, can you tell me more about it? And patient to say, oh, I've smoked 1 pack a day, 1 pack of cigarette for the past 30 years. Okay. Or I've smoked 10 for the past 30 years. Then you can also ask them, have you ever thought of quitting? No. Can ask, have you ever given any thoughts to quitting? Patient will say yes, patient will say no. If they say yes or no, it can depend on how you will manage the patient, because this will be important when you're managing your patient. Okay, so you're not just going to treat the MI and then that's it, and then in your mind you leave the room feeling like, oh, I gave morphine, oxygen, nitroglycerin, you know, I did everything. Like, no, fam, that's not enough. Okay, so you have to counsel them about smoking, about their diet. Okay, so you ask about alcohol, you ask about smoking, you ask them diet. You also ask about recreational drugs. Okay, for recreational drugs, you can add a bit more politeness. You know, by chance, do you take recreational drugs? Okay, because some people may feel offended, or you can say it's a question we routinely ask our patients. Okay, so but don't just say, oh, do you take recreational drugs? Because some people might feel like, no, you know. I mean, it's all about they're assessing your knowledge, you know. So some of those patients might be told to act in a certain way. Okay. Yeah. So so exercise. Tell me, are you physically active or do you exercise? However way you want to ask these things. Personally, I don't think there is a way. I just think you find the right way, but ask the right questions in the right way. Okay. All right. Now, sometimes the patient doesn't come with pain, right? Instead, so that's it all for the history. So let me just recap. Okay. So let's just recap our history. So whenever we're taking history, what comes to mind? The presenting complaint and then exploring. So you explore, presenting complaint. Okay. So that would be, again, if it's pain, so that would be our SOCRATES. Okay. So we'll do SOCRATES. We'll do our red flags. Okay. Or review of systems. Okay, so review of systems. Don't forget your review of systems, then your flaws, again, depending on if you think it's really important. You're a doctor, so you would definitely decide on the spot, do I need to ask this or not? But you have enough time, to be honest, to just ask. As long as you're not using sentences like, or like just say, like, for example, have you noticed any lumps or bumps, any change in your appetite, any change of weight? You don't have to, every sentence does not have to be, have you noticed any lumps or bumps? Have you noticed any change in your appetite? Have you noticed if you've lost weight recently? You don't have time for that. Okay, you don't have time for that. So just make your questions, you know, crisp and nice. Okay. All right, so we are just recapping. So we are exploring the chief complaint. We're doing our review of systems, red flags, our flaws, and then we said our P2 of TOSA. Okay. And then don't forget your social. Okay, social history and your, well, DESA. Well, you
please, I got lost on the flaws.
Yes, let me just write it out. So we have fever.
Would you please just repeat the, yeah, thank you.
Yeah, fever, lumps and bumps, appetite, weight loss, and sweating. Okay. So so essentially for every, like, there's almost no history you're going to take where you will not do this, honestly. Abdominal pain, chest pain. And when they say focused history, I can confirm to you that this is what they mean by focused history. Okay. Because, and the reason I'm saying this to tell you that you're going to have time. Don't feel like it's a lot. Maybe when you start practicing, it might feel like, oh my God, I would never finish. But the truth is, by the time you do 5 or 10 practice, you will be able to finish in the allotted time. Sorry, somebody asked me P2. So one of the P
Yes.
is previous episodes, right? So has this happened before? And what's the other P again? Past medical history. So have you been managed for any medical conditions? Okay. So have you been managed for any medical conditions, or have you done any operations in the past? I will keep checking the charts, from time to time to see. Okay. All right. So when they say focused history, you don't need to have arguments about, oh, trust me, focused history can never be so. And I learned that the hard way. And I say that again because in another station as well, I did the same thing where it was a result sharing station. So I asked, why did you have the test done? I explored all the symptoms. But I did not do like this maftosa because I felt like, oh, all I needed to do was just give her the results, and talk about it. So again, my data gathering was 2. My history taking was 2. So again, and from that, I've realized that, and I think anyways, again, this is just my opinion, that you need to ask all of these questions, okay? And you can do that in 5 minutes. Honestly, I promise you, you can do this in 5 minutes. DESA, social history, who do you live with, how are things at work, P2 maftosa, you can do all of this in 5 minutes, trust me, you can. The actors are not there to waste your time, okay? So don't worry about time. All right, yes, so I was saying, yes, so we've done the recap, yes, but I was saying that sometimes if the patient doesn't have pain and they have something like coughing, anybody remembers the mnemonic we use for that? What is that mnemonic called?
ODPARA.
ODPARA, thank you, yes, perfect.
It's called ODPARA.
Yes, ODPARA, yes. So the O would be onset, right? So when did this cough start? Okay, how long have you had it for? Okay, since you noticed it, has it been getting better or getting worse? Okay, so now we are exploring the progression. Okay, has anything made it better, alleviating? Sorry, I don't know how to spell like that. Has anything made it worse? So exacerbating. Okay. Oh my goodness. Why am I being a self-prophet? Okay. Anything makes it better, anything makes it worse. So alleviating, relieving, yes. Then any other symptoms you're experiencing. Okay. So anything else. Okay. So when did this cough start? How long have you had it for? Since you had it, have you noticed it's getting worse? Has anything made it better? Has anything made it worse? That's the R. So that's the alleviating, relieving factor. Okay. Or aggravating and relieving. Let me just write it as it is. Okay. Aggravating and relieving. Okay. Then anything else. Okay, so any other symptoms? Is there any other symptoms you're experiencing at the moment? And trust me, when you sound nice, sometimes they're just ready to give you all the information. Okay, so you go inside the room with a big smile on your face. Okay, in our time we had to wear masks. So I'm like, oh my God, I have to hide my pretty smile. I can't imagine. But anyways, I'm sure I still smile through the mask because there's something smile does to your voice. Actually, it modulates your voice. So try to smile as well. Okay, so it really helps. Anxiety is your greatest enemy. I will tell you that for sure. Okay. I'm not really sure if we have to wear masks this year. Unfortunately, I don't know. But I think when the official guide is released, right, they will probably send that information. All right. So onset, duration, progression, alleviating, relieving, anything else. And once you do ODPARA, it's the same thing. When I mean the same thing, red flags, flaws, review of system, P2 maftosa. So it's the same. So again, that's why you have make this this is your structure. This is your structure. Okay. Don't deviate so much from this. You may not ask in that order. And by the way, there is no you don't have to ask alleviating before relieving. Okay. Nobody's going to say, oh, you add duration before you ask severity. Nobody cares. I mean, when you guys practice among yourselves, somebody will say, oh, you're supposed to follow Socrates, but don't worry so much about that, okay? The important thing is you explore it. You explore the symptoms, okay? You don't have to ask in any order. However, sometimes it just makes sense and it just flows naturally to do that. Okay. If your patient has cough, so it's not enough to ODPARA it, right? So, and I think this is where some of us get confused as well. So it's not enough to ODPARA the cough. Okay, when did it start? Has it gotten better? You want to know what is the type of cough. Is it dry or productive? Okay, so it's not enough to ODPARA it. So you have to explore the cough further. Is it dry or productive? Then if it's dry, you can move on to the next question. But you know, if it's not dry, you have to ask other questions. So what other questions can we ask in a patient with cough?
Amount.
The amount, thank you.
The color.
Color, thank you. If it has any odor, right? If there is any blood in it, okay? So again, this will give you clues, right? So the amount, the color, so you know if it's yellow or greenish, you're thinking of infection. If it's reddish, you're thinking of blood. If it's foul smelling, you're thinking of abscess. Okay, so you can see how asking all these things will give you an idea of what is going on with your patient. Okay, so you have to explore further. So it's not enough to ODPARA the cough. It's not enough to say when did it start, how long have you had it for. Okay, but you need to further explore it. Does anybody have any? If you have any question, you can just use you can raise your hand as well. Okay. All right. Then if somebody has vomiting, it's the same thing, to be honest. You're going to ask how many episodes of vomiting have you experienced? As much as we don't ask color, we are going to ask what is the content of the vomit. Okay. And then it's important, was there blood in it? Right? So you can, so it doesn't matter the symptoms. Again, okay, well, for some, in diarrhea, again, diarrhea is the same. If you think about it, how many episodes of diarrhea have you had, right? Have you noticed any mucus in the diarrhea? Have you noticed any blood in it? Okay. I think those are like the main questions. You want to ask the episodes or the consistency, right? Is it watery? I mean, diarrhea should be watery, but anyways, it could be fatty actually. They could be steatorial, okay, to be fair. Yeah, so it could be fatty, right? So you want to ask the consistency, right? Can you describe it for me? Okay. Have you noticed any blood in it? Have you noticed any mucus? Again, it can tell you whether you should think of cancer, whether you should think of infection. Okay, it can give you a clue. It can help you figure out what is going on. For dizziness, there are certain questions you want to explore. Tiredness, you also ask tiredness, right? How long have you, first, when do you notice the tiredness? Does the tiredness get better with activity? Do you feel better when you rest? Okay, so these are some of the questions you will ask with tiredness. Okay, so this tiredness you're experiencing, have you noticed if it gets better with activity? Okay, is there any time of the day you feel more tired? Okay, then you can also ask, do you feel rested? And some people can even ODPARA it, right? When did you notice this tiredness? How long have you had All right, so how long have you had it for, right? So how long have you had this tiredness for? Since you notice it, has it been getting better? Okay, have you noticed anything that makes the tiredness worse? Have you noticed anything that makes it better? And the power of anything else. Because if you don't ask anything else, you are good to go on a roller coaster. Because tiredness, you're thinking depression, you're thinking hypothyroidism, you're thinking anemia. So don't go on a merry-go-round. Just ask a patient anything else. There is power in anything else. Trust me. Like there is power in but you don't say anything else. Is there any other symptom you're experiencing that you would like me to know, or that you would like me to address for you, or that you've noticed along with this? Okay, you will sound better than somebody who says anything else. Okay. Also, operate. You can also ask them to clarify, what do you mean by dizziness? Okay. Then you can say, oh, the room is spinning, or I just feel lightheaded. How many episodes? Has anything made it better? Has anything made it worse? So I mean, yeah, so duration, timing. So you can ODPARA all of this too. But I just wanted to point out that for diarrhea, for vomiting and cough, you need to explore them just a bit better, okay? Just a bit further. Remember that for NCA, the marking scheme is more rigid, more strict. It's like medical school, like they're really marking you like tick by tick. Did you ask this? Did you ask that? You know, they're marking actually. So for each one you ask, you're likely to get your points. Seizures as well, you can ask about seizures. Now, one thing that might be new to many of us, especially for UK exam, is icing the patient, okay? So when you think of ICE, those of you from US, I'm not talking of your immigration, okay? Don't mind me. All right. So when you think of ICE, there are actually 3 components you have to think of, and this helps to make your consultation also more patient-centered rather than doctor-centered. Okay, as much as you're there to shine, you are there to show them that you can care for their populace. Okay, that to an extent you understand the system. Okay, that's what you're there to demonstrate. So the I is idea. So after you take now, to be honest, many people I can tell you cannot agree when to do ICE, but I'm of the opinion that it doesn't matter when you do ICE as long as you ICE the patient. But my practice personally is I will do all my history, meaning I will SOCRATES, I will do my red flags, I will do my MAFTOSA, I will do my psychosocial history, and I would ICE my patient. Some people actually ICE after taking history, after taking the SOCRATES and the red flags and review of systems. From that point, some people actually ICE before they do the P2 MAFTOSA, okay? But again, like I said, I don't really think it matters where you do it, as long as it's not at the very end of it. Obviously, okay, so you cannot do it like after you've done talking, you've given the patient all the management, you've said, okay, this is what I'm to do for you. You're not asking the patient, have you given any thoughts? Obviously, like they just see you as you're just asking questions for the sake of asking. You don't really understand the flow. Okay, so ICE, your I is, have you given any thoughts to what could be the cause of your symptoms? You can say, you can paraphrase it to suit you. Okay, but this is what I say. Okay, so paraphrase it to your own taste, like to your personality. But the goal is you want to ask the patient, don't ask the patient, what do you think is wrong with you? Okay, when I say paraphrase, because again, during practice, you will hear all kinds of things, okay? So you can, and I think when you check the OSCE stuff, they also have ICE where, and Geeky Medics, check their website, okay? Type ICE, they would give you other ways you can ask, you can say the same thing. Is there anything you're particularly worried about? Some people can say, is there any concerns that you're having at the moment? Now, sometimes what I like to do is, because the patient has a chest pain, I would say, besides the chest pain, is there any other concern that you have at the moment? Just to show that I know that this chest pain bothers you, but I just need to know, is there more? Yes, what worries you the most today? Thank you. That's even better. What worries you the most today? Okay, so you can write, again, trust me, when I do all this, you have to be right. I hope you guys are writing pen and paper. Like they
Yes, actually.
listen to me without writing these things down. Okay. Yes. So I think somebody puts a better way, and I love that actually. What worries you the most today? Okay, so that's for your concern. Okay. Then your E is your expectation. Now, E can be later on, but again, you can just ask it all immediately. Is there anything you would want from us today? Okay, so is there anything you would like from us today? Okay, don't forget this. So it's not enough to take history from the patient without getting the patient perspective. That's the thing they're looking out for here, because they know that every doctor knows SOCRATES. Every doctor knows ODPARA. They know every doctor has a mnemonic for past medical history, allergy, medication, family. Okay, but what's going to make you stand out is being patient-centered. Okay, it's not about you so much, but getting the patient's ideas of what's going on. Okay? All right. So your expectations. Okay. So is there anything you want from us today? Then after you're done with your history, so again, all of that is part of history. I can just recap again. I love to recap just to be sure. Again, we started with, so let's say it's pain. Okay, let's not use pain this time. Let's just cough. So we'll ODPARA. Okay, explore the cough further. We'll do our red flags. We'll do a review of systems. We'll do a P3 maftosa. Okay, has this ever happened before? Okay, then we ice our patient. Did I miss a flaws? Yes, flaws. And then we ice our patients. Okay, and then we ice the patient. So this is your history taking. So you see that your initial consultation score and your history taking, you can get your, and I love NCA. They are not stingy with marks at all. Like they are not stingy at all. Like, I mean, I still looked at my results today or yesterday, and in a lot of places I got 4/4. Like they are not stingy. Yes, social DESA. Yeah, they are not stingy at all. Like they don't odd marks, they don't trick you, they are not there for drama. Yeah, so that's one thing I love about NCA, okay? So yeah, psychosocial. Hey, I don't know how to spell. How do you spell psych again? Yeah, psychosocial DESA. Okay. And trust me, it's easy to forget psychosocial, to be honest. If you're not used to practicing with it, and ICE. Okay, so these are the two parts that are very easy to forget. Your ICE and your so it's something you have to be conscious about. Okay, something you have to be intentional about. Okay. I love NCA. NCA, they are not stingy. Okay, it's not people that will give you 0.2 or whatever. Okay, they are very generous. A lot of my stations I got 4, like any place I got 2, I knew why I got a 2. Any place I got a 3, I knew, okay, I missed out something here. Okay, so, and any place they gave me a 0, I mean, I knew why I got a 0 there as well. So it's not the one that you go home and for the life of you cannot figure out what went wrong. Those of you that know, right? All right, so that's it anyway. So, but this is part of your examination, okay? So this is part of your exams, okay? Yeah, so review of systems. Review of systems, you're just asking everything. It might be from head to toe, any chest pain and difficulty breathing, tummy pain, changes in your bowel habits, any burning on urination. Exactly. Somebody put it out there. Yep. Very like, well, NCA, very low, like, honestly. Yeah. So, yeah. So your eyes, then after eyes, now to be honest, so it's like combined, right? So in the examination, you have to examine. So after you do this, so after you've taken your history, the next thing is to examine your patient, okay? Is to examine your patient. And please, when you examine your patient, okay, let's just use the slide. Yeah, there is a Siemens station as well in NCA. And we'll go over the Siemens station to the approach. All right, so for your examination, now before you do your exam, you can summarize your findings, okay? There is time. When I say summarize, just give the positive findings. So you said you had chest pain for the past 3 days, and it's been getting better, and it feels like a sharp kind of pain, and it moves to your left jaw. Is that right? And you also mentioned that you've been having sweating and fever. That's it, okay? You don't need to summarize the entire family history, past medical history, except you think it's really relevant, okay? So you can summarize your findings. Yes, that's why I say yes. So for even stations where you're examining, you still have to do that history. Because all right, so in examination station, I honestly did not run out of time in any station. Say, oh, I will take a history and move on. Like, please don't do the BRS minimum. Okay, it's £850. You didn't pay £850 to do the BRS minimum. Okay, and you fight until it's finished. Okay, so you fight till the end. You don't leave that room until you've exhausted yourself. I messed up big time, and I said, nope, it's not over until it's over. But let's continue so that we don't keep Oh, well, if the station says don't take any history, of course, you have to follow the task, okay? We have to obey the task. You have to read the task and understand what you're told to do. So if they say don't take a history, I mean, that's fake it, okay? You don't need to take a history at all, okay? But every station you need to take a history, they will always say take a focused history, okay? And focused history is all that. Now, before you examine, so you're going to summarize your findings. You're going to ask for permission to examine. So don't just, after taking history, okay, now I want to examine your chest, just be nice, be friendly. So after speaking to you, is it all right if I examine you? I mean, the patient will not say no, but just that, that politeness, that sweetness, it adds to your passing, okay? And when you're going to examine, ensure that a chaperone is present, okay? So say you're going to have a chaperone present in the room. You don't need to look for a chaperone. The examiner is already there. The truth is you need chaperone for intimate exam. However, digital rectal exam. Okay, so where you have to do rectal exam. Yes, but always say just practice it, So I would like to examine you, and during this examination, I'm going to have a chaperone present here with me. Okay, so just say that. It doesn't matter whether it's chest, whether it's belly, just have it as your practice, and say it to get your mark and move on. Okay, there's no need to argue. Oh, it's only in chest we have this my energy. All right, don't mind me. All right, then briefly explain what you would like to do in patient-friendly language. Okay, so for your chest exam, say I would like to look, I would like to feel, I would like to tap and listen. And technically, you've told them you're inspecting, you're palpating, you're percussing, and you're auscultating. You've actually said that. Okay? So I would like to look, you're inspecting. I would like to feel, you're palpating. I would like to tap. Okay? I would like to just sound weird now. And then I would like to listen with my stethoscope. Okay? Please bear with me. It should not be painful, okay? But if at any point you feel uncomfortable, please let me know and I will stop right away. Please add it. We'll get marks for examination. You will get marks for being systematic in your exam, okay? And anytime you're examining anybody, whether it's a knee exam, whether it's abdominal exam, whether it's cardiovascular exam, whether it's respiratory exam, you would inspect, you will palpate, you will percuss, and you will auscultate. Of course, for musculoskeletal, you will look, you will feel, and you will perform some movements, okay? And test for sensations. Okay, so that's what you will do for those exams. And those exams, please watch them on Geeky Medics. Practice them with your pillow. It doesn't matter. You don't have to get a real person. Exam, okay? If they say chest, then just do chest. But just listen to what they say. If they say do a chest exam, then just do chest exam. But if they say do... All right, so that's it. Just to recap, you're going to initiate the session. So you introduce yourself. The way you introduce yourself, please write it down. Not exactly how I say it, but write it down so that throughout your entire 12 stations, you will flow properly, okay? So, hello. I think I have a sample on my next slide. Oh, sorry, I didn't write it. I thought I copied it, sorry. But introduce yourself. Hello, I'm Esther Monday. I'm Dr. Monday. I'm wherever. Some people say you can say doctor. Some people say, oh, UK culture. If you say doctor, it looks like you're up there. I honestly don't think anybody cares, honestly. Introduce yourself the way you're most comfortable, okay? I think for my exam, I actually said I was Dr. Monday, all true. Well, if you say you're Esther Monday or you're Esther, nobody really cares, to be honest. As long as you introduce yourself properly. So I am Esther Monday, and I'm one of the doctors in the department. Some people argue you can say junior doctor. Some people say don't say junior doctor. Again, I don't think that's what makes or breaks the exam. That's my own humble opinion, okay? I really don't think it makes or breaks the exam. Just do what you're most comfortable with, okay? So, hello, I'm Esther Monday. I'm one of the doctors in the whatever department. Can you please confirm your name and date of birth, or your name and age, depending on, because from the doorway information, you're already giving that information, right? So they already gave you John Clark, 35 years old. Do we introduce yourself? Hello, I'm Esther Monday. I'm one of the doctors in the department. Can you please confirm your name and age? All right, so I understand that you're here today, build rapport. How are you doing today? Or what brings you in today? I understand, and take consent, okay? So I'm here to talk to you with regards to your visit. Is that okay? So explain what you're there for. Okay, I'm here to ask you a few questions about your health and see how I can assess you. Is that okay? So ask for consent, okay? Don't just assume that it's okay for the patient, okay? So take your time. And if you can, you should write it down so that it's just, and you can practice it, especially for those that have not done PLAB. So if this is really new for you, okay, after a long time, okay? Sometimes some of you is maybe after 1 year, after 2 years, after 3 years that you're doing all this clicking all over again, okay? So it's okay to write it down. Build rapport, okay? Again, smile. It's good to smile. It helps to build your confidence. Wash your hands. I mean, this is COVID, so every station, literally, before you enter, you have to sanitize, and when you come out, you have to sanitize. Okay, so yes, one thing I wanted to mention while we're talking about the history taking is signposting. Okay, meaning that, remember we said the flow was Socrates. Sorry, I just keep writing these things over and over. Socrates, red flags, review of systems, okay, flaws. So signposting is carrying the patient along, letting the patient know the next place you are. Because imagine after asking the pain, after asking any sweat, any weight loss, it's not nice to just jump to, does anybody in your family have any medical conditions? Okay, so you can ask patient, I'll be asking you some questions about your general health. Okay, it's not like you're asking permission, you're just kind of transitioning them, like letting them know where you're going to, like carrying the patient along. Okay, now I'd like to ask you some questions about your lifestyle. So don't just jump like medical history. No, when you say I'd like to ask you questions about your general health, you've actually covered this P2MA, right? You've covered allergies, you've covered medications, you've covered past medical history, past surgical history. Then you can signpost again. I'll just like to ask some questions about your family. Okay. You signpost. Then when you get to social, psychosocial, I would like to ask you some questions about your lifestyle. Okay, so make sure you signpost. Don't just jump, because as you that you are the patient, it's really weird when people go from family history and travel to do you drink and smoke. Like it's like, oh, like how? Like it's somehow shocking for you. Okay, so try to signpost. It also helps you be in control of your consultation. Okay, so it helps you be in control of your consultation, and it just helps the patient understand what you're doing. Because in some stations, you might need to ask sexual history, and it's just fair to say, are you sexually active? I know nobody would do that anyways, but you know, sometimes anxiety gets the worst of you. You would believe you cannot do. As I'm even saying this, you probably feel like I'm making stuff up, but I'm telling you what anxiety can do to you. Okay, however, you can be in control of your anxiety with good practice. Okay, so that out of the blues, because in your mind, when you're taking that history, you're already thinking, oh, this is something that is sexually. Before you just jump, oh, are you sexually active? And patient's like, bro, chill out. You know, don't mind me anyways. But yeah, the point is signpost. Okay, so the whole point of all this story is you need to signpost. Yeah, so building rapport is just asking the patient how they're doing, how they came in today, you know, just before you go to asking the questions of how can I be of help to you today, or what brings you in here today. Okay. I hope we have volunteers that are ready to practice all these things, because it will soon be my time to listen. All right. All right, so assess the patient starting point. Okay. Sorry, I need to clear this. That's why I keep clearing. Yeah, so we are clear on signposting, right? So don't forget to signpost. All right, so assess the patient's starting point. Okay, this is for when you're sharing results. Okay. So you can ask, can you tell me what you know about your condition so far? And this also comes in very handy in counseling stations. Okay, because in counseling station, you don't just want to go there and be blabbing. Like, it's not about you. Okay, it's not about you. So you don't just want to go there. Maybe, for example, you're counseling a patient on diabetes. Now, patients may already know definition of diabetes. Patient may know complication. But what the patient is concerned about is really how to take the medication. And it would be a shame for you to spend the first 5 minutes talking about, oh, diabetes is when you have no blood glucose. And then when you hear your 2 minutes warning bell, patient is like, doctor, you know, I have some concerns about how to take my medication. You know, so obviously, you know that you didn't do the task at that station. Okay, but we'll go over counseling in another session. Okay, so we'll go how to approach a counseling station. To be honest, counseling stations are chill stations. That's my opinion. Why? Because all you have to do is let your patient lead. Okay, you don't need to remember the flow of your Socrates. You don't need to remember the flow of your red flags. Okay, you're not really doing much thinking. However, in order to really make it chill, you have to have done your assignments, right? You have to have read Dr. Sharishka's book. You need to know if the patient asks you, oh, doctor, how many days will I stay in the hospital for? Of course, you need to know that information already. Doctor, how long will I take my medication for? Doctor, how long will I be discharged? Doctor, how long will the surgery? So you still have to do your own assignment, okay, in order for it to be a chill station, okay? If the patient is not asking, that's fine, okay? But in counseling stations, they usually have concerns. They have lots and lots of them. And that's why Geeky Medics or ski practice is also really good. It gives you an idea of the kind of questions that you'll be asked. And Dr. Sharishka book, okay? That book is really, really good. If you go blank, to be honest, I struggle with this, but I think it's okay to say that at the moment, I'm not able to produce an answer for you. It may not really be the best, but what you don't want to do is to give the wrong information, okay? It's somebody's asking that, what if you don't know the answer to the question, okay? It's better to say, honestly, yes, I will check and get back to you, honestly. However, if it's a question that's, imagine you guys are writing on that day, right? You're going to be at least 72. Now, if it's a question that at least 60 people know, you know that it will not look well on you if you are checking and getting back. But that is fair enough, okay? If that's it. If you genuinely blanked out, you can say, you know what, at the moment, I'm not able to answer this. Let me check and get back to you. You know, if you forget something, you can pause. If you don't know, very good to say, I'll check and get back. But if everybody knows, it will not look good on you. Pen and paper to note down our findings. Unfortunately, no, there is no pen and paper. If there was pen and paper, that would have been the best thing ever. There is no pen and paper. But I think it's so. Yes, screen. Yes, so giving the pain. Yes, and this is part of your rapport. Very, very good. I wrote this down. Sorry. This is part of your rapport. You see when your patient has chest pain at the moment, right? You can show like very nice interpersonal skills, like given that you have the pain at the moment, are you able to continue this discussion? I'm telling you, if your patient is in pain, don't just jump, and say, tell me more about the pain. Because I've seen people like, patient has chest pain, and they just say, tell me more. You can say, given that you have the pain, are you able to continue? Or if the patient looks comfortable, you can just say, are you comfortable to continue? And when you say sorry about that, now, another thing some of us do is when a patient says they have pain, we do say sorry about that, which in its own is not bad. But when you say it 3 times, your patient will legit frown. And I would say why, because my patient frowned. Like he literally raised his eyebrow. I think the first time I said sorry for the chest pain, the guy was impressed. Now, when he rated the severity, I said sorry again. Then when he said it affected his job, I still said the same sorry about that. At that point, the guy just raised his eyebrow like, girl, do you lack vocabulary? Anyways, that's just my own thoughts. But I did see him raise his eyebrow, okay? So, and you can also vary your vocabulary, okay? Oh, I can see you're quite uncomfortable. I can see this is quite difficult for you, okay? So you can also try to vary your vocabulary so you don't sound like you just learned that, I'm sorry about that, okay? Just adding that out there, okay? Yes. So yes, do the task. Again, ensure you carry the patient along, which is why you're always signposting. Okay, so you're not just talking and answering questions. Yeah, if you can. I mean, you can say it twice, but don't just say the same thing. I know this is difficult for you. I know it's like you can vary it. I can see this is quite challenging for you. I can see this is quite difficult for you. I can see you're in a quite bit of pain at this time. Oh, I'm really sorry to hear about your pain. Or even instead of just saying sorry about that, you can say, oh, I'm sorry to hear about your pain. Oh, I'm sorry you're experiencing this. It's still better than somebody just saying, sorry about that, sorry about that. Because literally that was what I said. I'll not lie. So, but it was after that exam I realized I needed to vary my vocabulary, okay? So just sharing that out there for you guys to pay attention to. All right, so ensure you carry your patients along. Again, always signpost. After you've done your history taking, you want to go to past medical history, I'd like to ask you some questions. I'd like to ask you about your family. I'd like to ask you about your lifestyle. Okay, I'd like to ask you some private personal questions. Okay, so ensure you signpost. Ensure you chunk and check. Okay, this will come along in counseling. Chunking and checking is when you talk, you ask if they're following you. You ask if they are okay with you. Okay, are you following me? Is it all right? Like I should have probably chunking and checking you guys as well. But I think I did that earlier. Are you guys following me? Don't mind me. All right, so I'm not getting any response, but I'll have to assume you guys are following me, right?
Yes, yeah.
All right.
Yes, we are. Yeah.
Okay.
Yeah.
All right, so always chunk and check. Thank you for your response. All right, ice your patients. Again, just summarizing what you need to do. Then in case it's a station where we have to examine and then we have to discuss the management. Be very patient-centered It's discussing the management. Again, read the task. If they say discuss with the examiner, then discuss with the examiner. If they say discuss with the patient, discuss with the patient. All right. So be very patient-centered, okay? There is a mnemonic that we use, and I think I learned that also last year. So it's called Essence. I don't necessarily have to follow it per se, although it's not looking like Essence here. That's because sometimes I forget to do, so I have to make up in my own way, okay? But the A is admit. So let's say your patient has a myocardial infarction. So, Mr. Jones, after speaking to you and examining you, I suspect that you may be having a heart attack at this time. Okay? Now, in order for us to, we'd like to admit you so that you can be treated properly. Is that okay? Don't just say we'll admit, we'll do further test, I would like to refer you. No, you're not patient friendly. Because when you say you admit, patients may say they want to go for a business conference, and you need to address that. Okay? So it's not okay to just say you admit. Ask their permission. Is that okay? Your investigation, the way I always remember investigation, I learned that from a YouTuber, okay? I think of bedside, bloods, and investigation, okay? So this is my patient with MI, okay? Bedside, ECG, chest x-ray, okay? Now for bloods, cardiac markers, troponin, FBC, then your maybe urinalysis, electrolytes, and the rest of them. Then investigation, okay, I could put chest x-ray as well, imaging, sorry, not investigation. So beds, blood sides, and imaging, okay? So imaging. But if you just remember it, that's fair enough, to be honest. But it just helped, and I really loved it, okay? So chest x-ray or maybe CT scan, okay? So when you come to investigation, you think bedside. So bedside will be urine test. Yes, the task will also be inside the cubicle as well. Yes, actually. And that was very helpful because in one of my stations, I noticed that I wasn't making progress with the patient. We were going back and forth. There's all these counseling psychiatry stations. And in my mind, I'm like, am I missing something? I feel like I'm doing everything right. And this woman is not replying me. So then I said, okay, give me a minute. And I looked back at the task and I realized what was missing. And then then I continued from there. So yes, you can always look inside. You can always look at it again. Okay, don't be afraid to look at it. It's better to look at it and do the right thing than to be afraid to look at it and then you're off points. Some of you understand my slang, but like you don't do the task. Okay, so it's better to look at it and make sure and ensure that you do the right task. Okay, so if it's okay. Yeah, so bedside, so you can think of ECG, your urine dipstick, okay, so those are your bedside tests, your bloods, urinalysis, electrolytes, LFTs, your imaging, your chest x-ray, your CT scan, okay? Somebody said, in which order do we have to do this? To be honest, it's what feels natural to you. Because some people actually, after they give diagnosis, they like to do investigations. So some people will say, I suspect you have a heart attack. In order for us to further confirm this, I'd like to do some more tests for you. Okay, then you can list the tests. Okay, but this is just in case somebody's struggling with knowing the flow, knowing the next step to do. Okay, but whatever seems the most natural. Like me, I don't follow this thing for the life of me. I honestly don't follow it, but I do know that it was shared last year, and I liked it, and some of us benefited from it as well. But personally, I give diagnosis and I investigate. Then I start managing, which is admit, refer, and treat. Okay, so I think of ART. Actually, that's what I did last year. I thought of ART. So admit, refer, and treat. Okay, then your seniors. You always have to involve your seniors. So admit, refer, treat. That was what worked for me. But investigation comes after diagnosis. Okay, so admit, investigation. If it's necessary to see the cardiologist or whatever specialist, you refer. The reason I wrote symptomatic treatment is for the life of me. For example, if somebody has, let's see, what can I think about? If somebody has a UTI, right, and they have a fever, to be honest, the only thing I always remember to give is antibiotics. I don't always remember to maybe give paracetamol for the fever. Or maybe somebody has pain and they have other issues. So what I always say, I always treat the disease, because remember that again, some of us have not done medical practice in how many years, okay? So because of that, I wrote it out for myself, like Esther. For example, if a patient has, let's think of GERD, right? No, not GERD. Does GERD work? I don't know. I can't think of any condition at the moment. Oh yes, let's say pulmonary embolism, right? Of course, I will not miss the IV heparin. I will not miss CT scan. But the truth is, I will not give patient pain medication for the pain. That's the truth. I will not give you medication for your pain. The reason why for MI, I will give medication for your pain is because I already memorized MONAP. If I had not memorized MONAP, I am sure I would just give you oxygen, nitroglycerin, aspirin. I will not remember to maybe give you morphine. Okay. So I always put symptomatic treatment. So meaning that if a patient has fever, give paracetamol. If they have pain, give paracetamol. Of course, unless they're allergic to it. Okay. So if there is pain medication, then treat whatever the issue is. So
Sorry, excuse me.
Yes.
What if the person has nausea?
Yes, exactly. That's good. And you give antiemetics. That's the point I'm trying to make. Yes. Yes. So for example, my patient that may have ulcer, right? I may give you something for the pain for the ulcer. I may give you maybe the antibiotics for the H. pylori, but I will not remember to give you something for the nausea that you're experiencing. Very good. That's the point I'm trying to emphasize. So that's why I wrote symptomatic treatment and then treatment for the disease, so that my brain will always remember that, Esther, they are two different things. Okay, you're not just treating the disease, you have to treat symptoms. And it also helps because sometimes you may not even know what to treat in a case. Okay. But okay, you're like, okay, after asking this patient has nausea, so I'll give antiemetic. This patient has pain, so I'll give pain medication. This patient has fever, I'll give paracetamol for the fever. And trust me, by the time you do that, more or less, and if they have infection, you give antibiotics. More or less, most likely you would have treated the patient. Most likely, you would have actually given the right treatment. So even when you don't know what to do, treat symptoms. Oh, yes, absolutely. After disclosing the diagnosis, yes. So yeah, you do have a heart attack, which is what we call a myocardial infarction. Or you can say you have a myocardial infarction, which is what we call a heart attack. Yes, so you can also use the medical terminology. Yes, very good. And please, don't forget you are a FY1 doctor, okay? So that means that anything you do, you need your seniors. Do you need to know the specific antibiotics? To be honest, I don't think you need to, honestly, because even for the other, like, you don't need to. You just need to say, I'll give you antibiotics according to the trust guidelines, okay? Just say, I'll give you antibiotics. However, what you can do to be even extra, for example, if a patient says, I'm allergic to penicillin, you can say something like, oh, I noted that you're allergic to penicillin. So I'll definitely make sure that we check and give you an alternative antibiotic according to the trust guidelines that would work for you. You've demonstrated safety to the examiner. You demonstrated active listening. You've demonstrated knowledge. Okay, so you don't need to say the specific antibiotic. If you have time to learn it, all well and good, but I'm gonna tell you, especially if you're doing PLAB 1 at the same time, it's a lot. Okay, it's a lot. So it's safe to just say antibiotics according to the trust guideline. In some stations, they would ask you to speak to the examiner. In some stations, just speaking to the patient is enough. The examiner is listening to you. Okay. All right. At what point do we have to talk about management? Management would be, again, depending on the task. So again, you can get stations where you have to take a history, you have to examine. So it's after you do those two, you will talk about management. There is another station where you have to take a history and interpret an X-ray. It's after you do those two that you will talk about the management. So usually management is when you've gotten to the point where you're ready to make a diagnosis. Okay, taking a history, you've examined. Okay, then you can discuss the management. Okay. All right. Yes, it's 10 minutes long, if I remember correctly. It's 10 minutes long. And trust me, the 10 minutes, in a lot of my stations, I had time. I didn't run out of time in almost any station. Almost any station. I didn't run out of time. Yeah, some people can. Yes, You can give provisional diagnosis and then do your investigation. Yeah. All right. Somebody's asking, how did I do PLAB 1 at the same time? To be honest, what I did okay, so do we have people that want to volunteer? Can 2 people signify already? After I share my experience of how I studied, then we can have maybe 1 or 2 persons. Let me just check the time. I just have 1 or 2 persons just practice a case, okay? But what I did was I was working as well. However, to be fair, my job is not that tasking. But what I did was I used to do NCA 2 hours every day. I started in the month of August, actually. I had a study partner, Dr. Aino. Okay, very amazing. It was actually one-on-one, so it was really good. Like, I had time to correct my errors, and luckily for me, she had done PLAB 2, so she was able to help me, identify areas where I made mistakes. Because I just know the theory, but she was studying for PLAB 2, so she was more into like doing the practical exams. Okay, so she was my study partner. So we do 2 hours on Monday, Tuesday, Wednesday, and Friday. Okay, I didn't do on Thursday because Thursday was busy. Then PLAB 1, I would just do like 3 hours as well every day. Okay, maybe like in the evenings. So I did 2 hours of NCA prep. Okay, and those 2 hours we would discuss at least 8 cases. Okay, 8 cases, sometimes 6, sometimes 8. But when we first started initially, it was a bit slow. It was like maybe 6 or closer to the exam, like in October. By then we already learned a lot we kind of knew the flow, we knew what to expect. So we did like 8 cases. Okay. So 3 hours, I did 3 hours of PLAB 1 and 2 hours of NCA. We did Sharishka, yes, definitely. I read the book, but more of OSCE. Yes, actually, if you're studying for PLAB 2, it will definitely help with NCA. I had a friend who did PLAB 2 in November 1st. That was last year, and then she did NCA November 9th. So she didn't have time for NCA, right? So it was after she did her PLAB 1 that she actually did her NCA. Yeah, so so I started studying although for PLAB 1 I started in June. However, I was just doing it like, how you feel like you have enough time because it's in November, but then August hits you hard in the face. By the time you have eligibility, like, bro, you only have September and October. That's it. So I had to take up the pace. So 3 hours of PLAB 1, 2 hours. Then I had another partner that I did 8 to 9. So with Dr. Aino, my time was 1 to 3. Okay. Then PLAB 1 was like, let's say, from 3 till 5 or 3 till 6. Okay. Then I had another partner that I did 8 to 9 with. But to be honest, that 8 to 9 I was always losing off. Sometimes we'll be taking history but that was towards the end because it got really intense and it just got really exhausting. And then I had to travel to the UK by the ending of October. So essentially, from the time I left, because I left to UK in October 25. So from October 25 till after November 3rd, I didn't study for NCA again. So again, I started NCA in August. So the whole of August, the whole of September, and then towards the end of October, I did NCA. Okay. So 2 hours every day is okay. As long as make sure you have a structure. It's a structure that is important. Okay. And of course, knowing the kind of cases to expect. So we did that. Then the 8 to 9, and that one, so I stopped it as well towards the end of October. Then after PLAB 1, November 3rd, my exam was November 9. Then I went back to review. Took me to Aspire. Okay, so that was where we just practiced like they had the mannequins, so we just did quick ABGs, blood tests, did the breast exam, testicular exam. So she took me through them. Okay.